to our YouTube channel. There, you're going to be able to see everything that we're planning for this year. Just as a reminder, we have Dr. Anderson on the 31st of May. This new series has been fantastic, and I hope you all can join us in May and June. In May, we're going to talk about the functionally univentricular heart. It's going to be a very good meeting. And now I want to introduce to Dr. Rima, who is the organizer of the Fetal series. And I'm sure we are going to have a fantastic meeting today. So if you guys find it useful, please share the link on YouTube to your colleagues on your teams. Thank you so much for being with us today. And thank you to all the speakers and panelists of today. It's with you, Rima.
Hi everyone, and good morning or good evening, wherever you are. This is our 30th episode of the relatively famous Fetal series. We've been going on for 3 years, and now we have 30 episodes. This episode is going to be really interesting. This is our first journal club in the first 3 years, and we are going to discuss an important topic in relation to the fetal cardiology, and this is going to be congenitally corrected transposition of great arteries, fetal diagnosis, associations, postnatal outcome. This is a collaborative research study from the Fetal Heart Society. And we made it in a way that everyone can understand, can join. So we are going to give first basics of the congenital corrected transposition. And our first speaker is going to be Dr. Deborah Ho. She's Associate Chief Ambulatory Pediatric Cardiology and Medical Director of Stanford Complex Biventricular Reconstruction Program. Wow, it sounds complex. Clinical Assistant Professor Pediatric Cardiology at Lucile Packard Children's Hospital, Stanford. And Dr. Ho is interested very much in congenital heart disease and lots of research, one of the eminent co-authors of the paper. Dr. Hu, would you kindly share your screen?
Yes, can you all see my screen? Oh, so before we start, it's really my privilege. Thank you so much to Dr. Bader and the organizers for having me today. I've been tasked with kind of giving an overview of CCTGA because I think with any fetal diagnosis, it's really important to understand the course, and so that we can appropriately counsel our patients. And so out of curiosity, I want to poll all of our participants today about CCTGA. As you all know, it's an extremely rare form of congenital heart disease. And so I would love to know if you participate in that poll, how many patients you currently take care of with CCTGA or that you've encountered. So I'll leave that for a moment. So like I said, today I'm going to do a broad overview of CCTGA and diagnosis, as well as management considerations. In my role as the medical director of the Stanford Biventricular Reconstruction Program, I have the privilege of caring for, maybe 10 to 20 of these patients a year at different stages in their lives. And so it's my privilege to share some of our insights with you all today. The Complex Biventricular Reconstruction Program includes our CCTGA program. Yeah, so it's a rare disease, right? So among our participants today, who are all, I'm sure, very experienced clinicians, overwhelmingly, we're seeing just a few in a career. So it's very interesting. So I'm going to start with a definition and then proceed with talking about anatomic variants, echo imaging considerations, heart block, and lastly, kind of management options and how to make that decision, because it can be complicated. So what is congenitally corrected transposition of the great arteries? By definition, it is atrioventricular and ventricular arterial discordance. So that means the atrium is connected to the wrong ventricle, and that ventricle is connected not to the type of great artery it normally is connected to. So as you can see in this diagram, right atrium to left ventricle, and left ventricle to the pulmonary circulation, whereas you have right ventricle to the aorta. Most commonly it exists in this L-looped form with kind of normal systemic venous return and pulmonary venous return. However, it can also, in about 5 to 10% of people, be what we call the mirror image. And so you have situs inversus essentially of the systemic and pulmonary veins, and therefore you have the left ventricle still on the left side, so L-looped, but again connected to the pulmonary arteries. And so, I trained under the Van Praaghen system. I'm very partial to that. And in the Van Praaghen terminology, we would call this LTGA. However, in this instance, I do think that congenitally corrected transposition, or CCTGA, is a more encompassing term because that also includes the 5 to 10% of IDD patients. And so I do prefer to call this CCTGA to include all forms of this type of anatomic variant. So CCTGA most commonly does not come on its own, as in the diagram on the previous slide. It usually comes with associated lesions. 10 to 20% has just CCTGA, nothing else, but the vast majority of patients have additional congenital heart defects. So VSDs are very common. They could be small, they could be large, they could be muscular, inlet, outlet, malalignment. Outflow tract obstruction is very common, and it can happen in many different ways. It could be muscular posterior deviation, as in this picture, or it could be due to valvular tissue through a VSD defect, causing subpulmonary obstruction. We can even have pulmonary atresia. Tricuspid valve abnormalities are also very common. You'll often see the term Epstein or Epstein-like tricuspid valve, and tricuspid regurgitation is also very common. And less commonly, you can have mitral valve abnormalities or heterotaxy and other unusual findings. So the initial step is diagnosis. So my wonderful colleague, Dr. Cohen, is going to talk about fetal and show some fetal pictures. And so I wanted to talk a little bit about the postnatal diagnosis and postnatal imaging, because CCTGA can be extraordinarily confusing to echo. I think it's very important to have, or even start with, the subxiphoid or subcostal sweeps, because that allows you to best understand what structures are connected to what and what their position in the body is. So, when I talk to my fellows, I talk about kind of our objective or objective planes when we're doing echocardiography, or orthogonal planes, versus what I call the relative planes that are defined by the position of the heart, right? So for example, if you're doing a peristernal long axis, that's defined by kind of the long axis LVOT view, where you can see towards the LV apex and up the LV aorta. And that's the definition of where the peristernal plane is. And so if you have a dextrocardic patient, or you have a patient who's mesocardic and that plane is not in its usual place, you adjust your probe to find that plane. And that's the definition of the peristernal view. However, with subxiphoid views or the subcostal views, you always place your probe in the same position when you're doing your frontal or long axis sweep, and then subsequently your sagittal or your short axis sweep. And so that's really helpful because it orients you, by looking at the picture, what side of the patient is what part of the picture. And that way you can tell where the structures are, both in relation to each other and in relation to the body. In CCTGA, not just because there can be dextrocardia or IDD, but in general, there's no fixed relationship between the ventricles or the great arteries. The great arteries could be side by side, they could be anterior, posterior. The ventricles themselves could be more side by side, or they could be one's a little bit more inferior posterior and one's a little more anterior inferior as we see in a normal heart. And so those relationships, spatial relationships, should be established early on in your echo so you understand what you're looking at. Otherwise, and even still, peristernal imaging is very confusing in CCTGA. So I'll show you some examples. Here in the subcostal sweep, you can see that the patient is dextrocardic, right? We have apex to the right. And in this freeze frame, we can see there's a ventricular septal defect. There's a smooth septal surface of the left-sided ventricle. This is IDD, so LV's on the right. But you can see it's connected to a great artery that appears to be very short, and you'll see that it branches. And in addition, here's the right ventricle that's on the right. But at the end of the sweep here, you can see the last thing you see is the left ventricle. So left ventricle is more inferior, close to the diaphragm, and also more anterior. So that's your great artery relationship. Back here, when we swept through the atria, you can see these are the pulmonary veins. So we have pulmonary veins coming into the right-sided atrium connected to a right-sided right ventricle, which is then connected to an aorta. Sometimes it's a little bit easier to see with color. And so here you can see with color a pulmonary artery that branches, and here's the aorta. And you can see the relationship is that the aorta is a little bit rightward and anterior compared to the pulmonary artery because we don't see them quite at the same time through our sweeps. Pulmonary artery first when we're coming from posterior, and then aorta last when we're anterior. Now, this is a sagittal view, okay? And so we know that in this patient, sagittal, this is going to be inferior towards the feet, this is going to be head, this is posterior, and this is anterior. And so we can see this smooth-walled left ventricle that's anterior and a little bit inferior compared to the right ventricle that's more posterior, and then coming up towards the aorta. This is the peristernal long axis for this patient. And, you know, depending on where you place the probe, often in the peristernal long, you won't even see both ventricles. I chose this because you can, but it's not immediately apparent which is the left ventricle versus which is the right ventricle. Sometimes you can use other connected structures as landmarks. For example, we know that the pulmonary artery is a little bit more posterior, and so you can see this great artery as opposed to one that I might expect to come off more anterior. This is likely a pulmonary valve. Of course, a sweep would help you understand that better. But because we know the left ventricle is a little more anterior, this is the left ventricle here, and this is the right ventricle. And sometimes that's important because you want to define, for example, tricuspid or mitral regurgitation from another view. Here's a patient who, of course, is levocardic, and we have left ventricle with a smooth septal surface here on the right side of the patient. So this patient is SLL, right ventricle is on this side. And this patient has a very common associated finding, which is that there is multi-level complex subvalvar pulmonary stenosis. So you can see how complex this subvalvar pulmonary stenosis is before you see the branching of the pulmonary arteries. This is another fairly common finding. So here, obviously in the two-dimensional picture, you can see there's a ventricular septal defect. And you can see this flap of likely accessory AV valve tissue that is coming through the defect, causing some narrowing in that subpulmonary region. Mitral valve abnormalities, as I mentioned, are very common. And, you know, classically not true Epstein in that we rarely see severe apical displacement, as you can find in severe Epstein. Usually the displacement is mild to moderate at most, and the amount of regurgitation is, again, like in Epstein, a little bit variable. You can have more significant displacement without as much regurgitation, but because there are commonly tricuspid anomalies, and also because of the right ventricular systemic position, tricuspid regurgitation is very common. Mitral valve abnormalities can also occur, but less commonly, about 10% of patients. Now, when we think about complete congenitally corrected transposition of the great arteries, heart block is something that's important to remember, and it can occur at any time for these patients, there's a 40% lifetime risk, and 4% of patients have heart block develop at birth, prior to birth, so already have heart block at birth. For individuals who don't have heart block at birth, every year the risk is about 2%. And interestingly, the risk is much higher if there's intact ventricular septum versus if there's a ventricular septal defect. This has to do with the displacement of the AV node, which is anteriorly and superiorly displaced with an elongated bundle of His. Very interestingly, there is no risk if patients have IDD type CCTGA, likely because there isn't this change in the location and anatomy of their AV node and bundle of His. Unfortunately, heart block does affect outcomes. In this one study that looked at risk factors for postoperative ventricular dysfunction, a pacemaker was a major risk factor, as you can see here. Now, the big question always is, I've diagnosed this, and what next? Or, whether that's postnatally or prenatally. And I think when it comes to CCTGA, there's a feeling that there's a lot of murkiness, there's a lot of options, there's a lot of uncertainty. And I think that can be true, but not in every case. And so I hope to break this down for everyone the way that I like to think about it. And essentially our options are no intervention, physiologic repair, anatomic repair, or what I call destination PA banding. Not all these options are available for every anatomy, so that's why that anatomy is really important to understand. And not every decision is appropriate in every context, right? So I think it's always a conversation with the family. What are their priorities? What do they hope for in their child's life? What do they want to prioritize? Do they want to take on some increased early risk, or would they like to have less risk with some known late complications? I think that's really the way to talk about it, because at the moment, there really is not clear data to say one is absolutely better than the other pathway. When I think about CCTGA, I think about it in three categories, okay? So patients who probably should not get surgery, and even at our center where we're very aggressive about offering surgery for patients with CCTGA, we would not offer patients who have this particular anatomy any form of surgical intervention. That's if you have CCTGA, intact ventricular septum, and moderate or more valvar pulmonary stenosis. So that means, why is it that we don't offer intervention? Well, there's no good intervention. And as an aside, these patients do very well because they have essentially an anatomic pulmonary artery band, through their valvar pulmonary stenosis. So a concept I think it's really important in CCTGA is the idea of septal position and septal shift. So this, of course, is what a normal heart looks like in cross-section. You have a rounded interventricular septum. The left ventricle is a circle because it's under high pressure. And you have a kind of crescent-shaped right ventricle. And as a result, your tricuspid valve is meant to close a crescent-shaped hole. And your mitral valve is meant to close a circular hole. Now, what happens when you have a right ventricle that's pumping to the body? The right ventricle becomes the circular cross-section, and your left ventricle becomes more of a D-shaped or a crescent shape. And while the mitral valve adapts fairly well to this different kind of more compressed shape, the tricuspid valve often does not, because it's being stretched from a more triangular shape into a circle. So often there's a coaptation defect in the center, which is the origin of tricuspid regurgitation. Now, if you're able to recreate this septal position by increasing the afterload of the left ventricle through, for example, moderate or more pulmonary stenosis or a pulmonary artery band, you can recreate this septal position or get the septum close to that and help support the function, particularly of the tricuspid valve, which is very important when you have a systemic right ventricle. So these patients should not get surgery. Patients who definitely need surgery are another category, right? So if you have inadequate pulmonary blood flow, there's not enough QP. Let's say you've got severe left ventricular outflow tract obstruction or pulmonary atresia. Let's say there's a very large VSD or significant tricuspid regurgitation. These are all indications in general for surgical intervention. So these patients probably need surgery. And the question is, what surgery should they get? Should they have a physiologic repair versus an anatomic repair? Physiologic repair being just address the associated lesions, let the right ventricle be the systemic ventricle, the pump to the body, let the left ventricle be the pump to the lungs, versus an anatomic repair, which will try to address both the additional findings as well as recreate the normal anatomic roles for the ventricles, allowing the morphologic left ventricle to be the systemic pump. You know, we all know that the morphologic left ventricle is a muscle that's made out, that's different from the morphologic right ventricle. And those two ventricles perform differently when they're told to pump to the body over the period of a lifetime. This middle category, I think, is the category where there's a little bit more debate about whether or not surgery is required. And I think that's true. CCTGA with intact ventricular septum or very small ventricular septal defect, no or mild pulmonary stenosis, no significant tricuspid regurgitation. Certainly, these are the patients who, you know, you see case reports of when they're 80 years old and have had 6 successful pregnancies without heart failure. These are the patients who show up in that category. And so there is an argument to be made for non-intervention. There's another school of thought that feels strongly that there is enough of a risk of right ventricular failure when you have a systemic right ventricle that an anatomic repair should be considered. And so for these patients, I think it's a conversation about what the parents feel is a priority, what treatments are most commonly performed in an institution that's available to the family, because, you know, we're talking about very complex surgery here, and surgical experience does matter. And so I think it's the conversations here should involve family and understand their priorities as well. Coming back to pulmonary artery banding and that concept of septal shift. So I think that pulmonary artery banding as an initial step towards LV training, meaning let's say there is a patient with CCTGA, intact ventricular septum, they would like to proceed with an anatomic repair. You can't just do a double switch on that patient, right? We need to somehow prepare the left ventricle, which has been pumping to a low pressure, 20 millimeter mercury pulmonary artery system for the lifespan. You cannot just do surgery and ask that ventricle to suddenly generate 100 millimeters of mercury pressure. And so what you have to do is you have to create training for the left ventricle by placing a pulmonary artery band. So that's commonly what we think of when we think of pulmonary artery bands and CCTGA. The other really important concept is this concept of septal shift that I keep talking about. And this is an example I want to show you all of a patient who was diagnosed quite late at age 9 when the primary care physician heard a murmur, and the murmur was this moderate to severe tricuspid regurgitation. You can see just as we sweep through how large that left-sided atrium has become. And so she underwent pulmonary artery banding both for left ventricular training and in hopes of being able to obtain a double switch. And this is her echo TEE on this side and the transthoracic prior to the pulmonary artery band. And this is that same patient after pulmonary artery band. And so you'll see, you can even tell, of course, 4 chambers is not the best way to see this, but even in the 4 chamber, you can see one, she has mild Epstein anomaly. She's got slight displacement of that valve. But more importantly, that the septum now is bowing into the right ventricle. And look what has happened to her tricuspid regurgitation. It's become mild or trivial even. And so that can, in and of itself, can be very powerful when you're talking about the longevity of a right ventricle. We know that right ventricular function is tied to tricuspid regurgitation. As right ventricles deteriorate, there's tricuspid regurgitation can occur, but also when you have the volume load of a tricuspid regurgitation, you can potentiate or increase the speed at which you have right ventricular failure. And so preserving the function of that tricuspid valve, reducing the risk of regurgitation is important. Here is a diagram of the anatomic repair, which we've been talking about. So you can see here's a baffle that's taking the blood from the IVC across to the left-sided right ventricle. At our center, we commonly do a Glenn instead of a full atrial switch. So that's why you see that here. And of course, the outflow tracts, you can either get a arterial switch, as we commonly perform in DTGA, or if there's pulmonary stenosis or atresia, a conduit, so a more Rastelli type where you baffle through the VSD to the aorta with an RV/P conduit. Of course, whenever we think of CCTGA, we always think of these incredible case reports of 50-year-olds, 90-year-olds who are diagnosed later in life, even potentially without heart failure, with CCTGA, who have had multiple successful pregnancies. But I just remind everyone that these are publishable because they are rare, they're reportable. They are not the common trajectory. And in general, what we know is that systemic right ventricles tend to fail over time. This study, looking at 200 patients in Scotland with systemic right ventricles, some were DTGA patients who had undergone atrial switch prior to the onset of arterial switches versus some with CCTGA. You can see that by patients' 30s and 40s, only we're looking at greater than 30% risk of death or transplant. And this does not account for the amount of tricuspid regurgitation or right ventricular dysfunction in the surviving 70%. As I've been saying, they found, again, systemic tricuspid regurgitation was associated with systemic right ventricular dysfunction. Physiologic repair, again, gives you a systemic right ventricle, and looking at a historical cohort, so, not necessarily applicable to today, but survival was poor. I think we'd hope for greater than 60% survival at 15 years. And many of them, the majority of them, had dysfunction of the right ventricle by 10 years, with a lot of tricuspid regurgitation. Interestingly, in this study, all the patients who underwent Fontan survived. Boston has published their experience looking at physiologic repairs on this column, and then anatomic repairs on this side, looking at the number of patients with dysfunction, severe or moderate. This is mild and no dysfunction, severe or moderate dysfunction at follow-up. And you can see it's substantially greater in the physiologic repair patients than in the anatomic repair patients. And of course, the long-term freedom from a combined endpoint of severe valvular regurgitation, right ventricular dysfunction, transplant, or death is really abysmal. Now, that being said, not every patient is a good candidate for anatomic repair. This is unpublished data from our center, where we're looking at patients that taken for PA banding for LV training. And what you'll notice is the age of the first PA band is very much related to the postoperative ejection fraction of the left ventricle. And this is postoperative following anatomic repair. And essentially, if the pulmonary artery band was placed before 1 year of age, everyone has a normal EF. Now, that's not to say that you can't have essentially a normal ejection fraction, normal functioning left ventricle with pulmonary artery banding at even age 10, right? So low 50s, that's a totally respectable EF after double switch. And so it's certainly possible, but we again have some patients whose function is less ideal. So This data, in addition to published data, suggests that optimal time for left ventricular training is under age 2. So placement of pulmonary artery band to probably 80 or 90% systemic under age 2 is ideal. Lastly, I think it's very important to consider a surgical center and volume. So, I'm not a cardiothoracic surgeon, but even I know that combining 2 very complicated surgeries, an atrial switch plus a Rastelli or an arterial switch, is not straightforward. And so places such as Boston Children's that are doing more of these, and even then, not that many, right, have really quite good outcomes in the high 80s, freedom from death or transplant, versus other centers. Now, first of all, this is reintervention. This is not death or transplant, so it's very different. But you can see how high the risk of reintervention is. And in this surgical center and international center, with seeing slightly fewer patients in the Boston program, you can see that their survival curve is very different. And so I think, this is a very important consideration, whether a center that has experience and does anatomic repairs commonly is available to you and your patient it should factor into your conversation. So in summary, I think CCTGA, it's a fascinating form of congenital heart disease. It can be very diverse. And so ongoing discussion with family and really understanding the lay of the land is essential when we're looking at management of our patients.
Thank you so much, Dr. Ho. A beautiful presentation. Just as we are always used to, what is the take-home message from your presentation? Because we have audience from different levels.
Yes. I think there's a few things to know. I think that when you have a right ventricle in the systemic position, whatever you can do to reduce the risk or reduce the amount of tricuspid regurgitation, that's going to help you keep that right ventricle healthy and functioning for the longest. But unfortunately, if you have a patient who's got a systemic right ventricle, it's important to talk to the family about the fact that that right ventricle, more likely than not, is going to fail within early adulthood.
You said something very important: physiologic repair and anatomic repair. So basically, if we can stick to physiologic repair better, if we can.
No, I think that from my perspective, if the surgical if the surgical program can support it, I would support an anatomic repair, because that puts the left ventricle in the position to pump to the body, which is the job it was meant to do.
It was the one with the PS. You said leave it as is, because it's a band. Yeah.
Yes, that's the only one, because there's no good surgical option. You don't want that pulmonary, that valvar pulmonary stenosis. You can't make that into an aortic valve. So that's the only one that I would say don't do surgery.
Thank you so much. Any of our important panelists would like to comment?
Rima, I have a comment. This is Anita Grady. Just maybe a clarifying question for you. You presented some unpublished data, and I'm particularly interested in the relationship of age to attempting a complicated double switch, and thinking of the patient who's not very straightforward, say 26 years old, who has a VSD and pulmonary stenosis, who presents for the first time and has maybe 3/4 or even a systemic LV pressure, and the argument could be made, well, they've been banded all along, so the fact that they're 26 years old, this one's okay to attempt a double switch. What is your institution doing now with these older patients, and do you have any data that's recent?
Yeah, we don't have recent data. A number of years ago, Dr. Hanley, who is our lead surgeon, did a number of conversions of DTGA patients who had initially undergone atrial switches, underwent left ventricular training, and then converted them to an arterial switch. And so that there, based on that experience, which is published, there can be success even with late left ventricular training. Usually, if we see a patient who's kind of above age 10, we say it's probably 50-50 or less that left ventricle is going to get to a point where we think it's ready for left ventricular training. Now, at our center, we do very detailed assessments of all patients before undergoing anatomic repair or a double switch. Every patient gets cardiac cath with pulmonary with a pressure volume looping assessment. We do an MRI on everyone, and if they're paced, then we get a gated CT to look at ejection fraction and mass. We want to understand what that left ventricular mass is. That's a little bit different if there's a VSD and they're kind of auto banded. Then we probably would go by the ejection fraction, what the pressure volume loop looks like, but more importantly, what the left ventricular pressure is. And yes, if they are 80 or 90% systemic, then we would say there is a good chance that patient could be successful as a double switch, even without further anatomic banding. Or we might say, let's say the patient is 70% systemic, but that left ventricle doesn't have to be trained from 20% systemic to 90% systemic. They only have to get from 70 to maybe 90. We would certainly still attempt left ventricular training. And we have had success, although they don't have data to show you that, not recent data anyway, but we certainly have had success with training older patients. But again, I think it really has to, it's really important to have a very detailed conversation with families about what the risk is, right? And that the long-term longevity of systemic left ventricle after a big surgery like a double switch in the context of congenital heart disease, we don't actually know what that longevity is. And it's a presumption, right? We are presuming that left ventricle, because it's going to be the shape it's supposed to be, because it's going to be doing the job it's meant to be, is going to last for a longer time. And ultimately, also, it's a left ventricle that we know better how to support from a pharmacological standpoint as well, because we do know so little about supporting systemic right ventricles. And so, for every family, that cost benefit pro con discussion is going to be different.
So opening this before we go to the next speaker. So we have different centers as a panelist. So Anita and Lisa, do you have different strategies for? We're not talking about Fetal CCTGA, honestly, because I think this is a different spectrum. But in general, correct transposition. What surgeries do you like to do for fetal and non-fetal corrected transpositions, please, Anita and Lisa, if possible.
Well, our lead surgeon worked with the Stanford group for quite a few years, so I would say our approach is not dissimilar from what Dr. Ho described. We are pretty aggressive once the patient arrives to our center at performing surgery, which is why I asked my question, because I do wonder when we don't have a good outcome in an older patient, should we have left that patient alone? Should we have gone straight to transplant? It's a question. But I would say as an institution, we have a similar approach to favor the anatomic repair.
And for us, it's a mix. And it really depends on the family and what they're wanting to do and the primary cardiologist. So we've gone both directions. We have been a bit burned with a couple of Nikitos that made people quite nervous about doing them, despite the fact that we've had very successful Nikitos and DTGAs with obstruction to the LV outflow. So that we still are in an area that there's a little bit of kind of debate almost every time, but then left to both the family and recognizing there's a little bit higher risk for sure, going after trying to do an anatomic repair up front. And so that's discussed with the family, but with the idea that long-term there can be better outcomes. I think it's always the toughest thing, though, is taking a very healthy little newborn with an L transposition intact septum who's got a nice little tricuspid valve and great function and think, oh, we're going to put you through big time surgery early in hopes that that will really get you out. It is always a little bit of a trick and a difficult discussion. I think there's still more data to be gathered here.
I agree completely, Lisa. And so sometimes when I counsel families, I also talk about destination pulmonary artery banding. If they're not sure they want to undergo a double switch, I think that's fine. I think placing a pulmonary artery band, even in a patient without significant tricuspid regurgitation, recreate the septal shift, the normal septal position, do everything you can to support that tricuspid valve being non-regurgitant for as long as you can. It's a pretty low, in the scheme of open heart surgery, there's no bypass run. It's a straightforward surgery patients undergo, or surgeons do it all the time. And you can kind of preserve your options. You don't ever have to do a double switch, but you can also preserve the longevity of that systemic right ventricle. But let's say many years down the line, you do want to do a double switch, you've already been trained. And so I think destination pulmonary artery band, and potentially in centers where an anatomic repair is not feasible, I think that's a really important concept.
Fully agree. So
I just
how
have
early?
a question. Yeah,
Oh.
Sorry, Lisa. Just for the audience as well, before going deep into do you all agree that the spectrum of the corrected transposition diagnosed in utero is different? I mean, the surgical options, the outcomes, from the ones that are diagnosed late in life or in childhood. Do you agree to that? So we know while we're counseling that these are two different spectrums, or it's not.
If I can
I would
answer the
agree.
question, if you don't mind me taking it, I think we should hear what Jen Cohen has to say, because I think what we are seeing in postnatal life and our experience is informing what we do in fetal life. And it's informing the shared decision making that Lisa has referred to. And unfortunately or fortunately, the spectrum of CCTGA is so wide that one size or one decision doesn't fit all. And hence the complexity, I think, of a rare disease and the combination of having so many manifestations. And as we still continue to have the same debate and rely on institutional experiences. But we've all seen 40-year-olds walk into a clinic and get the first-time diagnosis of CCTGA, so.
Sure. I wonder whether I can make a comment. This is Norman Silverman. Good morning. Lovely talk, Deb. Very nice. The one issue that I think Lisa brought up is taking a newborn and doing a double switch on a newborn is probably a bit hazardous. In my experience, when I was at Stanford, we had 3 patients. One survived and one died and one underwent transplant. It just suddenly happened like that. And I think that one has to be very careful about putting patients down on this pathway very early. On the other hand, it may not work very well when you put them, as you showed, after a year of age. It becomes also an important prognostic factor. The only other comment I wanted to make is that my own experience with banding the pulmonary artery and septal shift in corrected transposition was really not as successful as it was with converting a senning mustard into a systemic left ventricle. I want to know from you, Deborah, have you had any failures of not being able to shift the septum? Because I certainly have.
Yes, certainly. I think with any form of congenital heart disease, there are always cases that humble us, right? Where we think we understand the physiology, where we think we understand what's going on, and we don't. And so again, I'm very careful to counsel families that there is a risk of mortality and morbidity whenever you undergo open heart surgery, even for a pulmonary artery band, although it's certainly not in our recent experience that we had a mortality with that. We definitely have had cases where a pulmonary artery band has not been adequately helpful to shift the septum to improve tricuspid regurgitation. Usually it does if you're able to get to, above 50% systemic. And so that most commonly happens when it's a patient presenting a little bit later in life, that left ventricle becomes dysfunctional as we're tightening the band in the operating room. And so at our center, the pulmonary artery band placement and tightening happens with the echo team there. And so they're actively evaluating the degree of mitral regurgitation and left ventricular function as the surgeon is placing clips to tighten the band. And so they usually try to tighten it just to the brink of where the left ventricle starts to become dysfunctional and then come back a little bit. But there are cases in which you place a band in even a fairly what we would consider loose band, and that left ventricle becomes dysfunctional and does not fully recover even with releasing that band. And that usually happens when it's a later presentation. So, again, it's so important to counsel thoughtfully. And I think because of this, I really try to meet with all our families who often come to us by a wonderful surgeon. So they're not the surgeon a little bit different, and sometimes don't have the same type of long-term view or long-term kind of counseling that we do. So I'm a little bit of the downer sometimes, but I think that's important for families to understand going in.
Thank you so much. And now it's time to move to the hot topic of our webinar. And the speaker is going to be Dr. Jennifer Cohen. She's Assistant Professor of Pediatrics, Division of Pediatric Cardiology, Director of Pediatric and other Congenital Cardiac CT at Kravis Children's Hospital, Eshan School of Medicine at Mount Sinai, New York. Thank you, Dr. Cohen, for sharing this important info regarding your manuscript. You're the primary author, and we're honored to have you today.
Thank you so much. I think there were a couple of polls we were going to do before my talk, if possible, to pull up. If not, I'll just go ahead.
Now we can do that. Sasha, can you put the questions?
The polls, the questions, please. Sasha, are you there? Well, just to save time, we can go ahead. No problem.
Yeah,
Maybe
I'll keep going. All right. So thank you so much to Dr. Bader and the Congenital Heart Academy for the invitation to present our research to you. I'll basically go through the findings of our paper, which is entitled Congenitally Corrected Transposition of the Great Arteries, Fetal Diagnosis, Associations, and Postnatal Outcome, a Fetal Heart Society Research Collaborative Study. So Dr. Ho gave us wonderful background, but just briefly, CCTGA that I'll refer to as she defined, with atrioventricular and ventricular arterial discordance. As we discussed, it's a rare, varied, and complex form of congenital heart disease with the incidence at birth at 0.02 to 0.03 per 1,000 live births. Dr. Ho went through the frequency of these associated cardiac defects and postnatally diagnosed CCTGA. The numbers are similar in reported prenatal cohorts and are shown here, with intracardiac defects being common. Abnormal heart position is quite common. Isolated CCTGA is a minority and about 13 to 22%. The most common associated defect in fetal CCTGA is also a VSD, as well as pulmonary outflow tract obstruction and pulmonary atresia, abnormal tricuspid valve structure, aortic arch coarctation or hypoplasia. Aortic outflow tract obstruction is relatively rare at 4%, but important, as I'll talk about later on, as well as a hypoplastic right ventricle. Also, as Dr. Ho discussed, there's characteristic conduction system abnormalities, including AV block and reentry SVT, which can affect prognosis. I'll talk briefly about how we diagnose fetal CCTGA. Sometimes these patients come our way as fetal cardiologists because of abnormal cardiac position, or that may be one of the first things we notice on a situs sweep. This is an example of a patient with CCTGA and mesocardia. We could see the apex pointing directly straight. And sometimes they're referred to us for abnormal heart rhythm, as is this fetus in complete heart block. Of course, on any fetal, we want to identify what ventricle is which, and in CCTGA classic SLL segmental anatomy, we'll see L-loop ventricles. So as many of you know, to identify the RV, we look for the moderator band, the more apically displaced AV valve, and septal attachments of the AV valve. So in this image on the right, our right ventricle is on the left. And then to identify our LV, we look for the bullet-shaped or ballet slipper-shaped ventricle, as well as the smoothest septal surface. So in this image, our left ventricle is on the right, showing us L-loop ventricles. We'll also look at our outflows, of course. In CCTGA, there's typically parallel outflows. Of course, we could see this in other conotruncal abnormalities like DTGA or DORV, but also important in CCTGA. Here, aorta is anterior, and there's a VSD with mild PS. The three vessel view is also very important in CCTGA. This is labeled right and left, and going right to left and posterior to anterior, we have our SBC, our PA, and our aorta. So in classic CCTGA SLL, our aorta is anterior and leftward of our PA, as shown here. And then there is an association with CCTGA and aortic arch hypoplasia. This is a nice normal aortic arch. We can see it arising more anterior than typical. So what fetal CCTG studies had been done? Here I'll show the titles of some studies that had been done before ours. Most of these were limited by small number of patients and small number of institutions, with the largest study only having data on 43 patients postnatally, which led us to pursue our study. Just to briefly go over the largest study that had been done before by Day et al. They interestingly divided their CCTGA patients into 5 subgroups based on associated cardiac features. So those 5 subgroups were isolated CCTGA, those with a VSD, those with PS, those with Epstein abnormality, and a complex group. They looked at overall survival of those fetally diagnosed, and the overall 5-year survival was 80%, with no late deaths in their cohort after 5 years. They then looked at survival by grouping of associated cardiac lesions and saw the best outcome was in the PS group, which goes along with what Dr. Ho was saying about not intervening in this group. And the second best was in the isolated CCTGA group, and the worst outcome was in the Epstein group, although that group only had 3 patients, so limited really interpretation of that. And they also looked at survival by the presence of antenatal TR, which was mild or more TR. Only 3 patients had antenatal TR, but you could see that the outcome was worse in those patients. There's also, of course, many adult studies looking at what findings predict outcome in CCTGA. This is one of them that shows having significant TR and decreased RV function are associated with poor outcome. So the studies that were out there left us as fetal cardiologists with many unanswered questions that we attempted to answer by our study. We wondered, do associated lesions in CCTGA progress in utero? What associated lesions or rhythm abnormalities are associated with poor outcome? And what was the risk and timing of fetal heart block in this cohort? So the aim of our study was to describe the prenatal natural history, associated anomalies, and pre and postnatal outcome in fetuses diagnosed with CCTGA, and to determine the clinical and fetal echo predictors of poor outcome. Based on adult studies, we hypothesized that the presence of fetal TR, decreased RV function, or arrhythmia would be associated with a poor outcome. As far as our methods, this was a multi-center retrospective cohort study with the study protocol approved by the Fetal Heart Society Research Collaborative Committee. We ended up having 20 participating centers, 18 were in the US and 2 in Canada. And for our study, de-identified clinical and echo data from the time of diagnosis to the time of last follow-up was entered into a database and analyzed. For inclusion criteria, we included all fetuses diagnosed with CCTGA, again defined as atrioventricular and ventricular arterial discordance, with first fetal echo between 2004 and 2020. And we excluded those fetuses with a severely hypoplastic ventricle that would definitively preclude a 2-ventricle repair. So those that were sort of borderline and may be able to get a 2-ventricle repair were included, whereas those such as tricuspid atresia or DILV that technically had CCTGA, those were all excluded. And I'll come back to why this is important later on. As far as outcomes, our primary outcome was fetal death or transplant prior to 1 year of age. And we did some secondary analyses that I'll show you to assess for associations with fetal AV block, situs inversus, pre-excitation on EKG, and ending up with single ventricle physiology at last follow-up. So this slide gives us an overview of our cohort. We ended up having 205 fetuses in the study. 11 or 5% were lost to follow-up. 26 or 13% were terminated. There were 3 fetal demises, which was 1.5%, whereas 165 or 80% were live born. Of those live born, 152 had postnatal data available at 1 year of age. 3 of those ended up having a heart transplant 1 year. 7 died by 1 year, and the remaining 142 were alive without a transplant at 1 year of age. As far as the era of diagnosis, it does appear that we got better at diagnosing this fetally as time went on. So in our first third of the cohort, that represented about 10%. And then from 2010 to 2015, sort of the middle, that was 30% of our cohort. And then from 2015 to 2020, that represented 60%, sort of showing to us that we seem to diagnose this more in the later cohort, maybe perhaps with the addition of outflow views or 3-vessel views in our MFM screening. As far as maternal characteristics, as you can imagine, the reason for referral for fetal echo was most commonly a suspected structural cardiac abnormality or a rhythm abnormality, but sometimes they were incidentally diagnosed and were referred for things such as maternal diabetes, extracardiac anomaly, increased NT, a family history of congenital heart disease, or suboptimal views. Maternal diabetes in general was present in 16% of the cohort. Family history of congenital heart disease was quite prevalent in our study and was present in 11% of pregnancies or 23 fetuses, which is quite high. The most common was a family history of laterality defects like situs inversus, heterotaxy, or dextrocardia. There was also 1 each of CCTGA and DTGA. Septal defects were also relatively common, as were left heart obstructive lesions. Moving on to fetal characteristics, the diagnosis was made at a median gestational age of 23 weeks, but you could see was really throughout gestation, ranging from 13 to 38 weeks. Extracardiac anomalies were relatively rare, but not unheard of, and were diagnosed in 6%. And the most common extracardiac anomaly was a renal abnormality, followed by pulmonary. As far as genetics, there were 85 patients with invasive prenatal, meaning a CVS or an amniocentesis, or postnatal genetic testing, and 41% of these were done prenatally. This was found to be abnormal in 9 fetuses, though 4 of these were thought to be benign variants or variants of uncertain significance, whereas there were 5 pathologic abnormalities found. This included trisomy X in 1 fetus. This fetus had isolated CCTGA and ended up having RV failure early on and dying within the first few months of life. 1 fetus happened to also have a long QT gene abnormality. And then the other 3 abnormalities, the CCDC genes and the DIC3 gene, are heterotaxy genes. And there has been a lot of data out now that CCTGA and DTGA do seem to be associated with these laterality defects in dextrocardia or heterotaxy or abnormal sidedness, that those seem to be in that spectrum as opposed to DORV or TED and other conotruncal abnormalities. Interestingly, these abnormalities aren't going to be found on your standard karyotype or microarray, and certainly not on non-invasive testing. So I would encourage people who, with the family is very interested about genetics, getting more extensive genetic testing when possible, at least sending a heterotaxy panel, and if possible, even sending whole exome or whole genome sequencing. And I wouldn't be completely reassured if you have a normal karyotype and microarray in this population. So overall, of those with invasive or postnatal genetic testing, about 6% was abnormal, although I suspect that if we did whole exome sequencing on all these fetuses, that number would be a lot higher. So what associated lesions did our cohort have on first fetal echo? So isolated CCTGA was in the minority at 22%. Abnormal cardiac position, meaning mesocardia or dextrocardia, occurred in 33%, so quite common. Situs inversus with delooped ventricles was in 7%. A VSD was the most common abnormality in about 2/3 of patients and 68%, pulmonary outflow tract obstruction in 27%, with pulmonary atresia in an additional 11%, tricuspid valve structural abnormality in 20%. Aortic outflow tract obstruction was rare, as I mentioned before, and was 4%, but we'll see later on it is associated with our poor outcome, so important to look out for that. And aortic arch hypoplasia occurred in 11%. As far as hemodynamics on first fetal echo, TR was present in about 1/4 of our fetuses, although many of these were trivial, and there was only about 15% who had mild or greater TR, whereas MR was less common. RV hypoplasia of any degree occurred in about 10%. Most of these were mild, and severe hypoplasia was excluded from the study. And decreased RV or LV function was quite rare, only occurring in 2 fetuses, and both of those had heart block. Effusions were also relatively rare and occurred only in 3%. As far as fetal arrhythmia, fetal AV block at any point during the pregnancy occurred in 23 fetuses, or 11% of the cohort. None of the fetuses had first-degree AV block, but 10 had second-degree AV block at the time of diagnosis, and 13 had third-degree AV block at the time of diagnosis. The gestational age at AV block diagnosis was a median of 25 weeks, with an interquartile range of 23 to 28 weeks and a full range of 20 to 37 weeks. So most commonly seems to be diagnosed in that late second trimester. As far as pregnancy outcome of those 23 fetuses with fetal AV block, 17 of them were live born, 3 were terminated, 2 had a fetal death, so that yields a fetal death rate of about 11% if the fetus has AV block, and 1 was lost to follow-up. In those 17 live born, 14 of them had a pacemaker at last follow-up. So most likely with fetal AV block, there'll be pacemaker placed, but not all of them had a pacemaker placed at last follow-up. Also, SVT occurred in 3 fetuses. 1 of these fetuses was treated, 1 had a brief arrhythmia that self-resolved, and 1 fetus had SVT during delivery, and then also had SVT right when they were born, which needed to be treated. We did look in our study at the associations with fetal AV block to see if any anatomic factors were associated with fetal AV block. And we found that those with isolated CCTGA were actually more likely to have heart block than those who did have associated cardiac abnormalities, with an odds ratio of about 2.8. We also found that none of our situs inversus patients had heart block. And Dr. Ho touched on this a little bit. But this study that's quoted a lot when looking at heart block in these patients did an analysis of those patients with CCTGA with and without VSDs, and found that those with VSDs were less likely to have heart block than those without VSDs, and that may be due to the location of the AV node. Dr. Ho also showed this picture, but just to take home the point, that in SLL segmental anatomy, we know the AV node is located more anterior and superior than usual, and is more prone to injury either with surgery or spontaneously. Whereas in IDD, you may think that the AV node is just a mirror image of SLL, but it is not, and it is actually located in the normal location. So these patients are actually not at risk for heart block with IDD, whereas our SLL patients certainly are at quite a high risk. We did look if there were any other associations with situs inversus. Are they more or less likely to have certain anatomic features? And we found that situs inversus patients were less likely to have tricuspid valve structural abnormalities, meaning an epstenoid valve or tricuspid valve dysplasia, when none of our situs inversus fetuses having a tricuspid valve structural abnormality. And this has been shown in adult cohorts too. This study compares adults with CCTGA with situs inversus and situs solidus. And they found that none of the situs inversus patients had Epstein-like anomaly. So one of the things we wanted to look at as well was how important are serial fetal echoes in this cohort. And I think our data shows that they are very important, quite useful. Serial fetal echoes were performed in 135 fetuses, and 52 of those had at least 1 change noted, which was about 39% of those 135 fetuses. 30% of the cohort had a hemodynamic change, and 17% had a diagnostic change. The most common hemodynamic change, as you might expect, is an increase in TR, as well as an increase in LVOT obstruction. So I would caution, even if you don't see any TR on that first fetal echo, to keep following the patients relatively closely because there can be increasing TR that develops that may affect fetal well-being. And also, even if you think the pulmonary valve or subpulmonary valve region looks normal on initial fetal echo, I would always be suspicious that some degree of PS may develop over time. Only 3% of the cohort had a change in rhythm. And as far as diagnostic change on follow-up fetal echoes, the most common diagnostic change was a change in a VSD diagnosis. As I think we could all understand, VSDs are difficult to diagnose on fetal echo and to sometimes can be missed. Or a new diagnosis of Epstein's anomaly was the second most common diagnostic change noted on serial fetal echo. Now on to our postnatal data. So we ended up having 165 live-born infants, and 152 had postnatal data available at 1 year, and our primary outcome was at 1 year. The median gestational age at birth was 39 weeks, and preterm delivery occurred in 15% of the cohort, and these were usually for maternal indications rather than fetal indications. 63% were male. And the median follow-up time of our study was 3.7 years, all the way up to 16 years for our full range. We compared the prenatal findings to the postnatal findings and found that there was a hemodynamic change in 19% and a diagnostic change in 34%. And similar to our serial fetal echoes, the most common hemodynamic change was an increase in TR in postnatal echo compared to prenatal, or an increase in LVOT obstruction. And interestingly, there were 5 patients with new LVOT obstruction noted postnatally, even though there was not thought to be any LVOT obstruction or PS on fetal echo. And there were 4 patients that had PS that had progressed to pulmonary atresia by the time they were born. The most common diagnostic change, similar to our serial fetal echoes as well, was a change in VSD diagnosis and in tricuspid valve morphology. In addition, there were 11 patients, or 7%, where the RV was thought to be more hypoplastic postnatally than it was thought to be prenatally. So definitely things to keep an eye out for progressing or that we may miss are increased TR or an increased LVOT obstruction over time. 17% of our cohort went to the well-baby nursery after birth, while 83% went to the NICU. The hospitalization length of stay, as you can imagine, is extremely variable depending on associated lesions, with a median of 6 days and with a full range up to close to a year. The median surgeries per patient was 1, ranging from 0 to 5, and the number of patients who hadn't had surgery by last follow-up was 35%. The median cath per patient was 0, which ranged from 0 to 5, and the number of patients who hadn't had a cardiac cath by the time last follow-up was 42%. Right ventricular failure at any time point, data was collected for this and showed that 14% had RV failure, with a median age of RV failure of 2 months of age, with a full range of 0 to 98 months. The type of repair at last follow-up is shown here. 27% had an anatomic repair, which converted our LV to systemic, as Dr. Ho discussed. 5% had a physiologic repair, where just our associated defects were fixed, where the RV was left as systemic. 24 patients, or 15%, ended up having a single ventricle outcome, which means that they had a Fontan or plan for Fontan. And remember, to be included in the study, it had to be thought that the patient would not definitively have a single ventricle outcome. So we'll look at those patient characteristics a little more later on. There were 4 patients who had a 1.5 ventricle repair, 15 patients that had a PA band, and 39% that were unrepaired, with a couple that were early lost to follow-up. Looking at postnatal arrhythmia, postnatal heart block was present in 28%, or 43 patients at last follow-up. 17 of those were in our prenatal cohorts that were diagnosed with fetal AV block, and 26 were diagnosed with AV block postnatally. And 18 of these were associated with the procedure, while 8 were spontaneous. The most common procedure associated with AV block was a double switch with VSD closure and atrial switch for Stelli. There was a patient who ended up having AV block just from a cardiac cath. Spontaneous heart block, as I mentioned, occurred in 8 patients, with a median age of spontaneous heart block of 12 months, with a range of 0 to 103 months. First-degree heart block was present in 3 patients, and none of these progressed. Second-degree heart block was present more commonly and did progress in about 58% of the cohort to 3rd degree. And 86% of those with advanced 2nd or 3rd degree heart block did receive a pacemaker by last follow-up. So most of the time with advanced 2nd or 3rd degree, they'll get a pacemaker, but not always. A tachyarrhythmia was noted in 15%, and pre-excitation on EKG, which we know is an association with CCTGA, occurred in about 5%. We did look at if there were any associated anatomic factors that were more likely to make the patient to have pre-excitation, and not surprisingly, we found those who had a tricuspid valve structural abnormality, such as Epstein's, were more likely to have pre-excitation on EKG. And of course, there is a known association with isolated Epstein anomaly with pre-excitation. So more likely to have pre-excitation if your patient has an abnormal tricuspid valve in the setting of CCTGA, and less likely if that is not present. Looking at postnatal outcome, we had 11 patients that were listed for a heart transplant. 4 of them received a heart transplant, and 17 died at any time point during follow-up. Looking at our pre and postnatal outcome, so as I mentioned, our primary outcome was fetal death or death or transplant within the 1st year of age. So to look at this, we looked at this as a composite outcome with our prenatal cohort shown here and our postnatal cohort shown here, and did a stratified analysis. So this is a busy table, but I'll highlight the important points for you. Here are all the factors we looked at to see if they're associated with our poor outcome of fetal death or death or transplant prior to 1 year. And these factors that we found associated with this poor outcome were pulmonary atresia, mild or greater TR, mild or greater MR, aortic outflow tract obstruction, any fetal heart block, any fetal SVT, or any fetal arrhythmia, or progression on follow-up fetal echo with a worse effusion, increased aortic outflow tract obstruction, or worse hemodynamics on follow-up fetal echo. We did look at the outcome of death or transplant prior to 1 year in those patients that were live born already, so made it to birth, but then what's your risk of death or transplant prior to 1 year? So this excluded fetal death. And we basically found the same factors were associated with death or transplant at 1 year. The only difference was that mild or more TR and fetal heart block were no longer associated with outcome. So basically, if you were able to make it till birth with mild or more TR and fetal AV block, then that did not contribute to death or transplant by 1 year. We also looked on whether or not you had intervention, if that had an effect on whether you survived till 1 year, and the type of intervention, and neither of these things were associated with outcome. As I mentioned, there were a fair number of patients that ended up with a single ventricle outcome at last follow-up. So we wanted to look at what anatomic factors made it more likely that the patient would have a single ventricle outcome. And that's shown here in this table. The things that made it more likely that the patient would have single ventricle outcome are pulmonary atresia, tricuspid valve straddling, which certainly makes sense, mild or greater mitral regurgitation, which I think was an interesting finding, AV canal defect, dextrocardia, as well as heterotaxy. So these factors, if identified on first fetal echo, were more likely to be associated with a single ventricle outcome. Of course, there are some important limitations of this study. This was all retrospective data collection, so there are certainly limitations with that. In fetal diagnoses in general, we likely select for more severe disease, given that they came to our attention fetally. So I know Dr. Bader was asking before if this is a different cohort than those diagnosed postnatally, and I don't think we have data to prove this yet, but I'm sure that the outcome is worse in those diagnosed fetally compared to postnatally, given that those will come to our attention, usually if they have more complex associated defects or things like heart block. And overall, the outcomes we were looking for as far as our analysis were thankfully rare, but that did make some of our data analysis a little more limited. We do have some exciting future directions that we're going to do with this data. We're doing an ancillary study through the Fetal Heart Society where we're having sites update outcomes since this data was collected about 4 or 5 years ago at this point. So we'll get updated outcome data as well as analyzing subtypes of CCTGA to really give people firm data on what happens if you have isolated CCTGA, CCTGA with a hemodynamically significant VSD, and those with a VSD and PS. And then we also plan to review images to determine association of fetal echo findings with outcomes. So I'll just sum up with some take-home points and counseling pearls that sort of I learned from doing this study. So overall, genetic abnormalities and extracardiac anomalies occurred in about 6%, though I would caution that the genetic abnormalities are likely a lot higher, and I would encourage more extensive genetic testing if possible. And I do think of these differently than things like tetralogy of Fallot and DORV, in which there's much more likely to have sort of classic genetic abnormalities, such as 26q11 deletion, and are more likely to have extracardiac anomalies. Associated defects are common, with isolated CCTGA being rare. If you see a fetus that you think has isolated CCTGA, I'd always be extra vigilant to make sure you're not missing a small VSD, a subtle Epstein's, a little bit of PS, since overall arch hypoplasia is another one. Overall, it is in the minority to have isolated CCTGA. Fetal AV block in general is somewhat common, occurring in 11%, and is a risk factor for fetal demise. So if you have a fetus with AV block, sort of counsel them that the risk of fetal demise is about 11%. And these tend to be diagnosed more in the late second trimester. So you could think about screening more frequently during this time frame. And heart block is more common with isolated CCTGA, less common if you have associated lesions, and is extremely unlikely to happen if you have IDD segmental anatomy. So I think we can alter the frequency in which we see these patients based on their associated lesions and their segmental anatomy. Interval fetal echoes, hopefully I convinced you, are important because things can progress over time, especially TR and LVOT obstruction. Overall, the risk of fetal demise is low and short-term outcomes are good. And here, just to review our associations with poor outcome one more time, were pulmonary atresia, fetal mild or greater TR or MR, rhythm abnormalities, aortic outflow tract obstruction, or worsening hemodynamics on interval fetal echo. In particular, we had about 4 fetuses with aortic outflow tract obstruction and a moderate or more TR, and those fetuses did particularly poor. And I'd like to thank Fetal Heart Society, of course, for making this project possible. And Shubhi Srivastava, who's the senior author on this and has been an amazing mentor to me, and to all our contributing sites and working group who worked really hard to enter and analyze this data with me. Thank you so much.
Thank you, Dr. Cohn. Very important data. And now the floor is open to discussion. We are privileged to have the co-authors of this important paper, Dr. Srivastava, Chief of Pediatric Cardiology, co-director of Nemours Cardiac Center, Professor of Pediatrics, Nemours Children's Health, Wilmington, Delaware. And we also have the current president of the Fetal Heart Society, Dr. Professor Anita Mungredi, the director of Fetal Cardiovascular Program, a professor of clinical pediatrics, University of California, San Francisco. And also we have Dr. Hornberger, Chief of Pediatric Cardiology, Professor of Pediatrics, Division of Pediatric Cardiology, Strawley Children's Hospital, Edmonton, Canada. So now the floor is open to discussion because we have it's a multi-center study, and we are privileged to have also the head of the Fetal Heart Society, and I'm very grateful to Heart Society to sort of sponsor and improve the collaborative research among centers. Anita, would you like to talk about this input of your center in this study, and the difficulties, or how did it go?
Sure. I apologize. I'm in an elevator at the moment. Can you still hear me?
Yes.
Yes. Sorry. I think that the biggest take home from this type of work within the Fetal Heart Society, which has now done several collaborative efforts, is that for any one center to pull off something this big is very difficult. But when we work together, it's actually not that, it's not as onerous, and we don't need a lot of money to collect, 10, 15 patients that you might have at your center. And so I found it very gratifying that for what honestly was not so much effort for the individuals here at UCSF to be part of such a large series, really the definitive series on fetal diagnosis of this condition. So without sounding like I'm making a plug for the Fetal Heart Society in particular, I think what I'm trying to make a plug for is giving up the idea in congenital heart disease of saying, oh, well, everything that we deal with is rare, and just sitting down and doing organized multi-center studies so that we can advance our knowledge.
So what was new to you? You worked as a senior fetal cardiologist for years. What did this paper tell you that you didn't know from before?
I was thinking about asking Jen that myself. What sort of surprised us? I think nobody's surprised that if the harder you look for genetic abnormalities and single gene disorders, the more you're going to find. So I don't think that was a surprise. I was a bit surprised that the heart block occurred so early in this cohort of patients. I was sort of traditionally taught, I think I've even written it in a textbook chapter or two, that the heart block occurs late in CCTGA, and that actually turned out not to be the case. So I thought that was a bit surprising. As far as other surprise, I don't think there were any other big surprises, but what I get out of this is some solid numbers for counseling. The families want to know, what is the chance of this? What is the chance of that? And it's very unsatisfying to say, well, it either will or it won't. It's much more satisfying to say, well, when we looked at over 100 patients, 25% of them were exactly like your child, and they all did well. That's much more satisfying to me. So that's what I get out of it is really better numbers for counseling.
What about the factors that were predictors of in utero demise?
I I think I'd let the authors, or let Jen and Shubi speak to that. Whether because the numbers are getting somewhat small and the confidence intervals around those might be an issue. There also was a somewhat mixed sample. We did end up including patients with what I would consider more classic heterotaxy than CCTGA, even though, as was mentioned, CCTGA is probably more along the spectrum of a laterality defect than it is a conotruncal defect. But still, there were individual patients who didn't have the standard anatomy that you think of. They had an AV canal, or they had something else going on. So I'd let them speak to the predictors of in utero demise.
Thank you. Dr. Shrivastava, we're honored to have you here. You're a senior author of the paper. Could you enlighten us about as we said, that what was a surprise to you, and what were the predictors of in utero demise, and other things that you think you've learned and people would like the other audience to learn from that paper?
Thank you very much for having us here, first of all. But I think I would like to echo what Dr. Punredi said. What was surprising to me was the heart block incidence, and that it was more noted in just straightforward, simple CCTGA SLL category, rather than those associated with ventricular septal defects or more associated intracardiac abnormalities. So that was something that was surprising to me, that it was not only just SLL and that it would manifest in early second trimester, but also that it was like straightforward SLL patients that had the higher risk. So, and I think looking at the overall fetal viability, whenever you have an arrhythmia and have AV valve regurgitation, it puts you at high risk for in utero survival. So in terms of survival statistics, those were the ones that went into is what the findings that we also found in this study is having, those who had like a progressive valve regurgitation or an arrhythmia that were more likely to have fetal demise. So how do we take this data and how do we change our practice? I don't know. What I have done so far is the changes I've made is like the frequency of follow-up to monitor for heart block actually has been the major change in my clinical practice for straightforward congenitally corrected transpositions without associated other significant anomalies.
Do you bring them more frequent for follow-up?
I have started bringing them for follow-up after this, once they make the diagnosis every 2 weeks. So I don't know if that's an overkill or not, but this study did influence my my pattern of practice and also my discussions with my OB and MFM colleagues. So even if I am not seeing them as they are monitoring them, it helps me also share with them things to look out for because they do monitor, fetal heart rate and while being at their visits also.
What about outflow obstruction? Was it a factor?
It was a factor in this case, and I think it was surprising, like, when we found that out, like Jen and I, like what makes outflow obstruction so peculiar for in utero demise. So I don't know, like, because it was a very heterogeneous population. I do not use the presence or progression of outflow tract obstruction to counsel more in terms of severity of disease, but I do caution them in terms of overall long-term outcome. And I would like to know what the other panelists feel about that and how they would use this data to help them modify their practice and counseling.
Thank you. Dr. Hornberger, Lisa, do you want to come in, please?
Yeah, no, I mean, the study was fantastic because previous studies have been single center. This is now many more cases. And as Anita was saying, she was saying that it's actually really helpful because you feel more certain about how you're counseling and you're not just saying, oh, well, this is possible, this is possible. You actually have some data behind it. And I always find data helpful, at least certainly from my perspective in counseling. One of the things that we've done, though, from the heart block, and I think to some extent, some of the heart block is, of course, a biased population because they get referred to you and because they're identified as having block. But of course, those that progress was a bit of a different story. But one of the things that we've done is used our Doppler devices, send them home. And now I've got a way to do surveillance, but not be seeing that mom every 2 weeks. And so that's become kind of standard practice for any of our patients who are at some risk of arrhythmias, whether it be tachy or bradyarrhythmias. I think that's actually been very, very helpful in the last few years to kind of reduce unnecessary resource use, but have some security that those moms are getting sufficient surveillance, sufficient surveillance. So I think it's been a very important study. I think there's still more to be learned, obviously, both with respect to our prenatal counseling, prenatal surveillance and care, and then certainly postnatal care. I was just saying to Deborah behind the scenes that, this is a tough one to counsel, especially if your center doesn't have a definitive practice or a way that you manage these patients consistently. So then when I'm counseling a prenatal, I find it so much harder than a detransposition or a hypoblast where you just know what you're going to do. And you have this patient and you say, here's the gamut of possibilities. And these are things to be thinking about. And then after birth, those are all rediscussed. And I find this is probably one of the most challenging reasons to counsel.
So what do you counsel
Lisa,
them?
can I add to what you just said about, and I think, Rima, to the Fetal Heart Society, not just having a resource for all the centers to collaborate and send in data. I think the resource of having people like Anita and Lisa counseling and mentoring and getting the best out of the study is also, I think, having like these really known people with, a track of research helps make every study better. So just a plug in for Fetal Heart Society and research. And thank you to Anita and Lisa.
Just want to add, Lisa is the one in charge of the research committees, and she's I think behind a lot of work. She's also my ex-mentor. And Lisa, how would you, again, back to you, because people love to learn from what you do. How would you counsel? You said it's very difficult because of the future in utero. You don't know much about that. So what would be the message to be safe and counsel patients like that?
So firstly, I'm not the RCC lead. That's Shane Morris, and she's done an amazing job, and with lots of support from the collaborative committee, the research collaborative committee. I'm currently just the chair of the publications committee, but certainly a lot of us are engaged and very committed to the success of our field and the success of our colleagues who are just getting started or mid-career and wanting to continue to move forward, and identifying holes in what we do that actually ultimately can just get better, right? And we can provide better service to our patients. I was saying with respect to counseling, if you're seeing them early, and it becomes even harder when you're seeing them at 12 and 14 weeks, we've picked up a bunch that, not a bunch, but a couple of them then. And it becomes very, very hard, for the progression. And so we have some data there, but not necessarily all the way back at the first trimester. And so I'm very cautious with that counseling, but also knowing that some families and some cardiologists are not necessarily absolutely certain of a decision for anatomic repair, and without knowing for sure how things are going to progress. As Jennifer mentioned, sometimes the pulmonary outflow obstruction can be very subtle early, right? So not knowing how things are going to progress, I kind of present this spectrum of options and some of the difficulties with this diagnosis and what we're going to do after birth. So the families understand it is not just this is what we're going to do, but there is going to be more discussion. There's going to be, there's some uncertainty about for sure what we're going to do with the baby, but these are the possibilities. So I am pretty honest with them. I try not to confuse them, but it's probably one of the most confusing diagnoses that we have to counsel about. But try to kind of present kind of the gamut of possibilities of how we manage this without confusing them again.
So to make it simple, it depends where you see them. If you see them early, you ask them to come back. And then you talk about the key in fetal diagnosis, which is that we don't know what's happening in utero. Things can progress because the heart is still under development. And then you look for the AV valve regurgitation, outflow plaque obstruction. And from there, you would carry on counseling, and the message is bring them back more often than we used to do, like every 2 weeks, 3 weeks. If you find any deterioration, if you find AV valve regurgitation, you probably or outflow obstruction, you probably bring them more often, right?
Absolutely, but like I said, if there's none of that, I don't necessarily see them every 2-3 weeks because we have the Doppler devices if you're looking for block or tachyarrhythmias. But we would see them probably every 5-6 weeks in the absence of other things, just to make sure nothing evolves in the way of AV valve regurg or progressive obstruction.
Great. Dr. Cohen, you mentioned beautiful data, and you were sort of proposing of whole exome sequencing. Can you tell us more? What was the protocol for genetic testing in this paper?
Yeah, I mean, this was a retrospective study, so people just reported whatever genetic testing was done, and we had them report whether it was just non-invasive, NIPT, which, as we know, just really screens for any employees, or whether they had a CVS or amnio, what tests were done. Most of our patients just had a karyotype and microarray, which, as I mentioned, really those would not pick out many of the abnormalities that we know are associated with CCTGA. So we did have those 3 genes that are associated with laterality defects and heterotaxy, and those were found either on a heterotaxy panel, which is, I think, a panel of like 20, 30 genes that are associated with heterotaxy, or whole exome or whole genome sequencing. So it was I think only about 10 of our patients in the study actually had whole exome or whole genome sequencing. So most of them that had genetic testing were sort of your standard karyotype and microarray, but I would definitely encourage, if available, to get more extensive genetic testing.
That brings the question to the panel: is amniocentesis necessary? Because you're not going to do whole exome sequence without amnio, right? So, and whole exome has the answer most of the time. So, to the panel, do we propose whole exome antenatally, or it's really not cost effective and not health effective? Wait until after delivery. Can we have our important panelist answer this question, please? When to do amnio, yes or no, and ask for whole exome sequence, yes or no?
So I can answer for our center because we've been doing a lot of whole exome sequencing in fetal life. Had nothing to do with me. Grants from our MFMs have paid for all of that over the years. But so we you know, if the patient will consent to an invasive procedure, then we'll start with microarray and reflex to whole exome or whole genome, which we can now offer rapid whole exome sequencing, really just a matter of a week or two. So they actually can make decisions based on the information. I'm a strong believer that we should get these data, but also a strong believer in patient autonomy, and you know, if it won't make a difference to the pregnant person during the pregnancy, then we just offer it postnatally. So I don't think that there necessarily needs to be a push to do whole exome during the pregnancy, but I do think that that until we are doing whole exome sequencing universally for congenital heart disease, we're going to be behind because you know, every new thing that we start looking for, we find a ton of it. So very much in favor of offering it if you're in a setting that can do it like mine, with a rapid turnaround, so that it's actually useful to the pregnant people and to the team during the pregnancy. Otherwise, postnatally should be an option as well.
Lisa, what do you think?
Completely agree with Anita. We don't currently have the rapid turnaround whole exome, so that is a limitation in terms of making decisions for the pregnancy. But unless we're catching them very, very early, but we do offer it, and ultimately certainly encourage them to have that testing after birth if there's a continued pregnancy.
Were you surprised about the percentage of genetic abnormality in this lesion? Were you surprised this lesion? Were you surprised about the percentage of genetic abnormality in the study, the 6%?
No, I mean, we're learning more and more with all this new advanced testing that there are definitely things that we've not known about. I think in the past, where we've said, oh, you know, is genetic testing for transposition necessary? Well, it was at a time that we didn't have this testing. And now that we understand that there is a relatively small, it's not the majority, but have this risk, it's more information that we can provide families with respect to long-term health, and also things that we may be able to do to try to improve their clinical status long-term.
Thank you. Dr. Srivastava, do you agree to what the Anita and Lisa said, or do you want to add anything to that?
I'm complete agreement with what Anita and Lisa have said. Even in our center and the prior centers that I've practiced, in terms of amniocentesis, it's a shared decision making whether it's needed or not. And whole exome sequencing has become something we can offer. But that's where we are also. So
I think the ethics of having a whole exome sequencing is a question. Because you know things that you don't want to know as a patient, I mean, or as a person.
And sometimes you get results you don't know what to do with.
Yeah. And
well, that's Rima, if I could say that brings up the absolute necessity of working with a good genetic counseling team. It's important for the patient to be counseled prior to the testing, to specifically address what you're saying. You may find collateral information that you weren't looking for, and now you know, and have to deal with. Patients can opt to not have that information disclosed. So if you don't want information about breast cancer risk genes, you don't want information about other adult onset diseases, they can redact that from the reports. So, but certainly, as a pediatric cardiologist, I cannot possibly understand and keep up with all the nuances of that. And so it definitely is a team effort, and even interpretation of whole exome sequencing must be done by experts. This is not something where you just get a test like a CBC and you know instantly what all of the information means.
You read the 3 pages that come as a result of the test, and you get confused, honestly. As you said, a genetic counselor and a genetic team is very important. We cannot end this webinar without having the godfather of our series, Dr. Silverman. What is your comment? I hope he's still here. Well, probably he's not there. So I'd like to thank you all for coming, and I'd like to thank the Fetal Heart Society, and like to thank our audience. This is a recorded webinar. You will find it on the YouTube just now or in a few hours. You click on the Fetal series and you can find our 30 episodes. And also you can click to the Fetal Heart Society, find all their webinars and very important educational data on it. Thank you and have a very good day.